Okay, are we ready?
Ready?
So I'm Bob Centaur, and um, just for those people who are on for the first time, this is Unremarkable Labs, and the un is in parentheses because sometimes labs are clearly remarkable, and sometimes you really have to think twice to use the labs. The purpose of this is to get us all better at taking advantage of the data that we're collecting already. We order labs all the time, but the experience of many clinician educators is that we don't interpret them as well as we should. I was talking to one of our colleagues who becomes an attending tomorrow. She becomes an assistant professor tomorrow, who in 2 weeks is going to do our first hematology labs analysis. And she gets referrals all the time. Patients have to travel to see her, and really all she has to do is interpret the labs that the referral physician did not know how to interpret. So we want to go ahead and try to help you with that. My passion is acid base and electrolytes, and so that's what we're going to do today. That's what we did last week. That's what we'll do next week. But we're going to add more labs to it. The most important thing, if you're in the chat and we explain something and it doesn't make sense, please send us a question and make us go back over it. The purpose of this is for you to learn and understand, and Seema will be monitoring the chat and will stop me cold in my tracks if there's a problem. So Stephen?
Yeah, so I will, just so everyone's oriented, we're going to each introduce ourselves so you know what we're doing during this session. So I'm Stephen Alon. I'm one of the chiefs here at UAB, went to UAB for med school as well, and I will be presenting the case. Sean, do you want to introduce yourself?
As long as I can find the unmute button, I can. So I'm Sean. I'm also one of the chiefs. I went to Central Michigan for medical school. Hopefully going to be doing rheumatology next. I'll be running the board, so if there's any typos on the board, you can blame me. It's not reflective of the other people here. And I'll let Seema tell you guys about her.
Yeah, I'm Seema Kumar, also a chief alongside with Sean and Stephen. I went to medical school at LSU Shreveport, and so I will be moderating the chat as Dr. Centaur mentioned. So I will be looking for your question. I promise you multiple people will be thinking it. So we will stop them when they go on their tangents and make sure we're all on the same page.
And we've got Lindsay Shipley here, who's helping with the wrap up and keeping track of the pearls Dr. Centaur teaches.
Yeah, hi everybody. I know most of you from BMR. I'm also a CP Solvers member and also a third-year resident at UAB. So excited to be here and give you guys some teaching points today.
Great. And then
chief next year.
And chief next year.
And then our discussants, if you guys wouldn't mind introducing yourselves. Olivia, you can go first.
Okay, cool. I'm Olivia Hudson. Most people just call me Livy, and I'm a PGY2 at UAB.
All right, great.
Hey everyone, my name is Carl Zenaldine. I'm a new intern here. I went to med school at the Medical College of Georgia, and yeah, excited to be here in Birmingham, and thanks for having me as a part of this.
Great. Okay, so we're going to do some space learning. We talked about elevated bicarbonates in both of our cases last week. So I want to go over a couple of things. Number one, the top fishbone represents the first case we did. And one of the things that I overlooked was that the potassium was normal. So here's how it went. We had an elevated bicarb, and the resident immediately said, we need to get some kind of a blood gas to make sure that it's not COPD with compensation. We got a blood gas, and it was a metabolic alkalosis. Now, often in that situation, what you do is you check a urine chloride. And if the urine chloride is low, that means it's something to do with volume. And then you have to try to sort out what kind of volume problem it is. If the urine chloride is high, so-called saline responsive, then it's something to do with aldo or aldo-like substances. And Sean has put together a really good quick schema for doing this. Now, what's interesting here is that on the left side, where we have GI hydrogen losses, laxatives, remote diuretics, volume contraction, all of those usually have hypokalemia. And that was probably a clue, because this case was sort of a strange case because the volume contraction was due to hypercalcemia. It did quickly correct with volume. If the urine chloride had been high, then what you do is you work patients up for aldo. Sometimes you'll see this with as a response to diuretics. You can see it with real licorice, not the fake licorice that we sell in the United States sometimes. And you can see with Little's, Barter's, and Gittleman syndrome. You can see with a variety of inborn errors of metabolism that will give you elevated aldo or aldo-like numbers. Just a caution here, most primary hyperaldosteronism does not have a metabolic alkalosis and hypokalemia. We're way underdiagnosing aldo and hypertension patients because most of them do not get hypokalemia. So if you have a 30-year-old who all of a sudden shows up with hypertension and there's no good reason for them to have hypertension, screening for aldo is worthwhile regardless of the potassium. Now, the other thing that's interesting is the second case. And if you look at the fishbone that we have right here, notice that there's a very large anion gap. And what's surprising about this case and what's unremarkable is that we start out with a normal bicarb, but yet if you calculate the anion gap is 31. So by definition, that was an anion gap acidosis. But then if you also do the delta gap, and there are a variety of different ways to do this. Some people do a delta-delta, some people do a delta gap. The way I do it is the way that Sean has put together this schema. What I do is I take the observed anion gap, which was 31, and then I do an expected anion gap. And as an estimate, at UAB for years, we've used albumin times 3. It's not exactly right, but it's pretty close. So his gap was 31. His albumin, I believe, was 4.5 or something like that. The patient had a fairly normal, let's just say it was 4. So that was an excess gap of 19. That's what we call the delta gap. You then add that 19 back to the 25 of his observed bicarb, and you'd see if all of the unmeasured gap were changed to bicarb, that he would have a very high bicarb. This is a very common situation in diabetic ketoacidosis, in volume contraction with lactic acidosis. And so knowing that you're dealing with two metabolic problems really helps you. If you add it back, which we do here, then you had a corrected bicarb of, let's see, it was the difference was 19. So if we added it back, it would have been 44. And so that would be a metabolic alkalosis. Every now and then you can get a normal gap acidosis and an anion gap acidosis. This will often happen in end-stage kidney disease or close to end-stage kidney disease. I hope that makes sense. Does anybody have any questions in the chat, Seema?
No, we're good. That was a good wrap up of those. You know, we had those two interesting cases last time. So I'm glad we kind of reviewed some of those high points and pearls from then.
Okay, so now Carl and Libby are going to be on what the clinical problem solvers call the lukewarm seat. And we're putting them on the spot. And the idea is to find out what they know and what they need to learn. This stuff is difficult. And if they get everything right, then I'll retire. No, I've already retired, so I don't have to retire again. So because you're the intern, Carl, and because you're so brave, and because you went to Medical College of Georgia, you get to just tell us what's abnormal in this fishbone. Is there anybody in the chat who doesn't understand the fishbone? Somebody had asked me about that. Nobody's saying anything, Seema. Okay, good.
Okay.
So Carl, I'll give you actually a little more. I'll even tell you a one-liner of history. So this is a middle-aged gentleman who comes in with about 2 days of fever and weakness. And then I'll let you review the BMP and tell me what you think.
All right, so taking a look, sodium 141 is within normal limits, 135 to 145. Potassium also within normal limits. Chloride is kind of on the upper end of normal. I think it's 95 to 105. Bicarb of 10 is definitely lower than normal limits. So right away, I'm thinking about potential acidosis. BUN is 28, which is slightly elevated as well. And then creatinine is 1.6. So that's also elevated. So yeah, I guess right away, I'm thinking about a potential acidosis. I'd like to find out whether this is primary metabolic acidosis or a respiratory acidosis or compensation. And then with the elevated creatinine, I'm thinking about an acute kidney injury. So I'd like to know like baseline creatinine, and then considering the presentation with fever and shortness of breath, maybe I'm leaning towards a respiratory acidosis. So next, I'd like to find out the arterial CO2.
Okay, so let's go over that. There's one other thing that that you probably ought to do. Anytime you have one of these, you probably ought to calculate the anion gap. That might help you here.
Okay. So sodium, so 141 minus chloride plus bicarb, so 114. 141 minus 114, 7.
Yeah, asking interns to do math in their head is really not fair.
Yeah. All right. So 27, and that's like an elevated anion gap.
Right. So let's Libby, let's go ahead and do that delta gap and see if this is a pure. By definition, he has a metabolic acidosis. Anytime you have an increased anion gap, you have a metabolic acidosis.
Okay.
So Libby, let's play that delta gap thing. Is this just a pure metabolic acidosis?
Okay, so with the delta gap, so you take the observed anion gap, so that's 27, minus the expected, which is 12, which equals 15. Right. So that would mean that there is an additional non-anion gap metabolic acidosis.
No, okay, so I didn't explain it well. I apologize.
Okay. Sorry.
So you add that 15 back to the 10.
Oh, sorry. Okay, so 15. So that's 25. Okay, so then that would mean there's an additional metabolic alkalosis.
No, it means that it's normal.
Oh,
So
well, I thought 24 was normal.
Bicarb.
Okay.
So thank you so much for pointing out my deficiency in teaching this. Because it's sort of it's a hard thing, and everybody thinks they understand it until they have to put it into practice. And so my guess is that it makes more sense now that we had to go through that.
Yes. Can we repeat that one more time? Of how are you calculating this delta gap, and what do you do with the number to know, is it normal? Is there something else going on?
Step number one is assume what the normal gap is. We haven't been told the albumin, but I'm going to assume the patient has a normal albumin for now and say that the normal gap is 12. That gap is actually 27. So the delta is the difference between the normal gap and the observed gap and the normal gap, and that's 15. Okay, so that's the delta. What do we do with that? So we have this gap that has some unknown anion in it. If we assume that all of that gap became bicarb, then we'd know what the bicarb was before this anion gap developed. So we add that back to the observed bicarb, which is 10. So 15 plus 10 gets us back to 25, and that's a normal bicarb. Did that make more sense to the chat and to Olivia and Carl?
Yeah, yes, that made more sense.
Yes, I
Okay.
think we're good. That was helpful.
I'm so glad that it was difficult and that y'all let me know that it was difficult, because I have the curse of knowledge. It makes too much sense to me, and I have to figure out the right way to say it. So I appreciate that. Okay.
Before we go on, this would bring in something that we talked about last time, but a great question in the chat. Would we ever correct sodium for hyperglycemia before calculating the anion gap? Which is a great
Yeah. And we went over that before, and you do not. And the reason is whatever causes the sodium to go up or down also causes the chloride to go up or down. And so both sides of the equation are lowered the same amount or raised the same amount. Okay, so Carl, I'm going to help you out here. If you had a respiratory acidosis, what would be the PCO2? Are you muted, Carl?
Yeah, sorry about that. So PCO2 would be elevated, so above
Correct.
45.
So with a low bicarb, if that was a compensation for something, and bicarb will never compensate that much, that would be compensation not for respiratory acidosis, but for respiratory alkalosis. So once you saw the bicarb of 10, you knew that that's too low for compensation. So you knew that there was some kind of metabolic acidosis, and then you can figure out it's an anion gap acidosis.
Okay.
So I mentioned last time in passing the mnemonic that I use for making sure that I don't miss anything that could be going on for the anion gap. Now, I'm not trying to solve the case here. I'm trying to teach. So I came up with KILU, K-I-L-U. And what we're going to do, the reason I like KILU rather than mud piles is because it really breaks down into a schema, and it gives me a way to think of all the different categories. If you don't like it, that's perfectly fine. But most people that I've taught it to have found it to be a nice way to keep things or organized. So Sean is just a beast. This is so great. So let's do ketoacidosis first. So could this be diabetic ketoacidosis? Well, 3 years ago, I would have said no because the glucose is 90. But Carl and Libby, how could this be diabetic ketoacidosis? What could the patient be taking that would give you ketoacidosis and a normal glucose?
Those new medications
Yeah.
that I know they are using more in like heart failure. I can't remember. Yeah, SGLT2 inhibitors. Exactly. And we've had cases reported to us. They're in the literature all the time. It's not real common, but you don't want to miss it, because as soon as you see that anion gap, you start going down a sepsis protocol. And if it's really just ketoacidosis, you really need an insulin protocol. Okay, alcoholic ketoacidosis. We see quite often. The caution with alcoholic ketoacidosis is that if you just measure urine ketones and serum ketones, at most hospitals, they're only checking acetoacetate. And a percentage of alcoholic ketoacidosis is anaerobic,
and goes over to beta hydroxybutyrate. Now, some hospitals measure beta hydroxybutyrate and then you don't have that problem. But I don't think either one of our hospitals do that. I know the VA doesn't. Do they check beta hydroxybutyrate at University Hospital?
I don't know if you have to order it special or not.
Special. I worked at a community hospital up in Huntsville, and if you ordered ketones, you got beta hydroxybutyrate. And then starvation ketosis we see all the time. And so this brings up a very interesting point, is how aggressively should we be working up this anion gap? And there's a wonderful article in the New England Journal of Medicine a number of years ago that says once you get to 25, you can almost always identify what the problem is. And certainly once it gets to 30. So at 27, we're going to figure out what the unmeasured anion is. And it could be very, very, very important. A lot of patients come in with an anion gap of about 18. And they're a little volume contracted and maybe halfway hypotensive, maybe just down a little bit. I don't necessarily work those people up. Good residents will give them some volume and give them some food and see if they get better over the next 24 hours. So I don't think you have to work all those people up. At 27, we have to work it up. Starvation ketosis usually doesn't give you a gap of greater than 25. It can, but usually doesn't. Okay, any questions about ketoacidosis? So this could be alcoholic ketoacidosis, but we didn't get that history yet. So the next letter is I for ingestions. So let's talk about the three big ones that we always think about. We think about ethylene glycol, methanol, and salicylates. Now, ethanol is, you can get an anion gap with ethanol, but that's alcoholic ketoacidosis. So I usually don't put that in there, but that's okay. Ethylene glycol and methanol are very dangerous, and we don't want to miss those. Salicylates are interesting. So here's the question for Carl and Libby. What on blood gases would make us think of a salicylate overdose? And some salicylate overdoses are unintentional. People just take a lot of aspirin and then might be on sulfasalazine also. There's a number of ways you can get too much salicylates.
I feel like they always, like when they first present, it's a respiratory alkalosis.
That's correct. So, and this can be a test question. If you get either a VBG or an ABG on this patient, and I would on this patient, because we don't know what's going on. Maybe with the fever, they've been taking a lot of salicylates. And we see a respiratory alkalosis also, and we'll do Winner's equation if they're kind enough to give us a blood gas. And if there's a respiratory alkalosis, then we're going to think strongly about salicylates. Carl, how are we going to screen for ethylene glycol and methanol? Even though there's nothing about this history that makes us think that this patient might have overdosed on ethylene glycol and methanol.
Yeah, so we could look at the osmotic gap, I think.
The osmotic gap is 100% right.
Yeah.
And so just send off a serum osm. If it comes back too high for our calculated osms, then we're going to get excited. I would do that in somebody like this. It might be unnecessary, but every now and then you'll get fooled. So those are the big three. There are several others that are worth knowing about. So acetaminophen is like a renal boards question now. Too much acetaminophen can lead to oxyproline buildup. It's usually seen in small elderly women who take what would normally be normal amounts of acetaminophen, and it gets reported. I don't know exactly how many reports in the literature, but not a lot. We did have one case at UAB that a resident told me about. where there was an anion gap acidosis after acetaminophen overdose, and they sent off the oxyproline level and it was elevated. So I'd keep that in the back of my mind. Iron is really important in pediatrics. If anybody's med peds and infants get into their mom's iron, especially if it's liquid iron, you can see this. I've never seen it in adults because I've never seen an adult who would take iron, much less overdose on it. INH used to be a very common problem. It is no longer a problem in the United States because of directly observed therapy. It actually causes the lactic acidosis. So that brings us to L, lactic acidosis. Okay, are we doing aspirin is in goodies powder, Sean? That's correct. It's in a bunch of those things. Any questions thus far from the chat? Chat's doing good? Chat's happy? Okay, so let's think about lactic acidosis. Type A is, okay, so Amr, our buddy from Prague, asked a question here. Which of the ingestions elevate osm gap? So the osm gap is ethylene glycol, methanol, but you have to adjust for an alcohol level. So it's any toxic alcohol. I hope that helps. So routine lactic acidosis is dying tissue. So that's shock, that's dying limb, that's dying gut. All experienced third years know that if a patient comes in with severe abdominal pain at my age and there's nothing obvious, you check a lactic acid. Now here's the important thing for all interns to learn that third year residents know. The lactic acid level goes up before the anion gap goes up. So you will see, and the reason it's important with abdominal pain, if you have severe abdominal pain, nothing obvious, you get a CT scan, nothing's too obvious, but the lactic acid level is up, you have dying gut. And you got to go look back real carefully because that's the only way you're going to save the patient. Because the lactic acid, and that's very, very clear in the emergency medicine literature. That's very well documented. Okay, we see anaerobic metabolism all the time in shock. And then type B is very confusing in the literature. When I first looked at this a number of years ago when I was doing a CPC on an anion gap acidosis, they confine type B to tumors. They're usually liquid tumors, usually lymphomas or leukemias, but they can be solid tumors that produce lactic acid. Most people now also lump medication induced. And let's see if we can get Carl and Libby to come up with some medications that you need to think about when you have lactic acidosis.
I'm pretty sure linazolid can.
Absolutely, that's correct. What's the one we invoke way too often?
Is it an antibiotic?
No, metformin.
Oh, okay. Oh, yeah.
Okay, and then there is, well, let's see, there are a couple other ones. So the IV lorazepam, we rarely use that anymore. We used to use it all the time. And for those people who don't know what lorazepam is, that's Ativan. And the problem is not the drug. The problem is what the drug's dissolved in. It's dissolved in propylene glycol. And if you have too much propylene glycol, it gets broken down to acetoacetate and lactic acid. And sometimes it's D-lactic acid and sometimes it's L-lactic acid. So if you are in a situation where you have to give more than 7 milligrams per hour of lorazepam, you need to be aware for this. And that will actually, because it's propylene glycol, that will give you an elevated osm gap. So you could check for the osm gap in someone who's on IV lorazepam. This used to be really important but they've really decreased the use of IV lorazepam in the ICU. And then D-lactic acidosis is a very unusual thing when you have a bacterial overgrowth in the gut. We used to see it more often when more patients were getting Roux-en-Y's for weight loss because they tend to have short gut syndromes. But every now and then you'll see somebody who has some kind of a GI problem that is a short gut and bacterial overgrowth. And this is a syndrome where the gap is around 18, according to the best review article that I read. And they act and feel drunk with a normal alcohol level. Chad Bursky, who's the head of our GI fellowship, when he was a resident, presented a case to me that we actually wrote up discussing that syndrome. And you'll see it every now and then. It's worth having in the back of your mind, but it's usually not a big anion gap. And the last letter is U for uremia, and that's usually phosphates and sulfates. So let's go ahead and apply Kill-U back to our patient. Okay, so Carl, let's go back. We have an increased anion gap. Do you suspect ketoacidosis?
There's not much to work with in terms of history, but as we talked about, glucose seems all right. So I would say less likely.
So we'd have to get a history to see if the fever and weakness was preventing the patient from eating. So a lot of patients will come in with a mild ketoacidosis, but probably not the whole gap. We don't have an alcohol history, so that's not going to make sense. So Libby, what's your gut reaction when you have fever and weakness? And let's explain the slightly elevated creatinine and slightly elevated BUN, or actually modestly elevated.
Yeah, so I would think that I'd be concerned that there's a metabolic acidosis going on. The fever makes me think of infection, which makes me think of sepsis, and then AKI from secondary to that. So that's kind of where my mind first goes.
Okay, so now you get to hear one of my pet peeves, which many people have heard over and over again. We cannot attribute this to an AKI yet because we just met the patient. We have to fulfill certain things before it's an AKI. And
do we just call it an azotemia?
So yeah, so I just say there's an elevated creatinine that's unexplained. We're not sure. You have to first see, is it volume? And then you have to make sure there's not obstruction. And so I don't call it an AKI for another day or two because that implies injury, and this could just be severe volume contraction. And with severe volume contraction, then we probably have some lactic acidosis and probably have some ketoacidosis. Now, since we were worried about salicylates, can we get a blood gas or a VBG?
Yeah, I think it would, so we can take a look at like expected compensation.
Exactly.
Sure. You guys want an ABG?
We would love one.
All right, great. So we've got an ABG. This is on a room air. pH is 7.52 with a CO2 of 12 and an O2 of 100.
Okay, Carl, you asked for it, you got it.
All right, I'm a little bit confused.
Good.
Because
that's exactly what I would expect in the first week of internship. I would expect you to be confused by this.
Yep, I'm confused about a lot. Yeah, I mean, so I guess the pH is 7.52, so it's actually alkalotic. And then, to be honest, I'm actually, what is it? I'm not sure what the 12 and 100 refer to at the moment.
Excellent, excellent. So the 12 is the PCO2 and the 100 is the O2. This is on room air. So we're going to go through a couple things here, but I'm going to see what Libby thinks first.
Yeah, so with the pH being 7.52 and the CO2 being down, like there's like this a respiratory compromise. I guess so I guess you would say they're primarily respiratory alkalosis. Would that be right?
So this is a respiratory alkalosis and an anion gap acidosis. It's both. By definition, the anion gap is 27, so it's definitely an anion gap acidosis. Now, this one's easy because the fact that the pH is high means we know that the PCO2 is too low. But just because the one formula that I try to remember is Winner's formula, let's just go over Winner's formula. And so if we weren't 100% sure, so Winner's formula, which Sean knows what I'm going to do, that, you know, when someone was once your intern, they know all your tricks. So the expected PCO2, now in this, you actually use the bicarb from the ABG. And the reason for that is in the original article that Winner's the senior author on, all they had was a blood gas and it was a regression equation. So I'm going to assume that the PCO2, the bicarb was the same on the blood gas. And so 1.5 times 10 is 15 plus 8 is 23 plus or minus 2. This PCO2 is way low. Now the question we have to ask is the PCO2 that low in order to maintain oxygenation? Or is something else driving the respiratory alkalosis? Now, you don't need to have a PO2 of 100, do you? You do pretty well with 80. So I would be thinking that I better think of what Libby taught me earlier about anion gap acidosis and respiratory alkalosis. What did you tell me, Libby?
I think, well, I don't remember now. Didn't I just say it's like a primary respiratory alkalosis? I don't know if I said anything too.
With what?
With a with an anion gap metabolic acidosis.
With salicylates.
Oh yeah, that they usually present with a respiratory alkalosis in the beginning.
Right. So in this patient, you have to check a salicylate level. So let's think about this. All we know is fever and weakness. What do people take when they have fevers? They take aspirin.
NSAIDs, Tylenol.
NSAIDs, Tylenol, aspirin. So this could just be the patient had a fever, took a bunch of salicylates. Because of the fever, because of the salicylates, has both an anion gap and a respiratory alkalosis. Now that may or may not be right. If we calculate an AA gradient, and I went over this last week, but if we calculate the AA gradient, this patient has an AA gradient of about 35. So how did I do that?
That was my question.
Okay. So, this patient's in his 50s.
And before we do the AA gradient, I just wanted to bring up Brandon's question. Could we review an example of why PCO2 would be low to maintain oxygenation? Yeah.
So if the PO2 was 75, let's say with normal respirations, the PO2 dropped to 50. You get hypoxic, and so you hyperventilate. By definition, a low PCO2 is hyperventilation. By definition, okay, which we should separate from tachypnea. So by definition, this patient is hyperventilating, and he doesn't need to get his PCO2 down down to 12 to have a good O2 sat. If he'd gotten it down to where we had expected a PCO2 of 23, he'd still have a PO2 in the 85 to 90 range. So one of two things is going on. Either that he took salicylates, or that he has a central mechanism that's making him hyperventilate. But he's not doing it to maintain his O2 sat. Does that make sense? Did I say that right?
Yes.
So his AA gradient is elevated. It's 35. So remember, that's the alveolar arterial gradient. He's on room air. So remember, we had that equation: 760 millimeters of mercury minus 47% water vapor is 713. Remember that? And then you multiplied by the FiO2, which is 21%. And so the alveolar O2 is approximately 150 in Birmingham. It's going to be lower in Denver or at high altitude. And then you take the PO2 plus the PCO2 divided by the respiratory quotient. We always assume the respiratory quotient is 0.8. If you divide 12 by 0.8, you get 15. 15 and 100 is 115. Subtract that from 150, and you get 35. Now that's a slightly increased AA gradient, but it's not a major league increase in AA gradient. So I don't think that this is his lungs making him hyperventilate. There's something else making him hyperventilate. And so I'm going to get a salicylate level, but now I need to know more about this guy. I'm going to give him some volume, and I need to know more about the fever and the weakness. So now we really have to go back and ask some questions. So Carl and Libby, I'll let Carl go first. What do you want to know about this guy?
And I'm going to let Carl think for a second. I wanted to get two questions in on the AA gradient while we were on that topic.
Right.
So if you have a high AA gradient, does that mean there's a problem at the lungs for exchange?
Yes.
Okay.
Yeah,
And
so
can
the
you-
AA gradient, as Mohit has just put in the chat, does increase with age. But I think if you look it up at this guy's age, his AA gradient is probably going to be about 20. At an intern's age, it's going to be about 10, something like that. I don't remember the exact formula. If someone could look that up and post that, that would be nice. I start to get worried in the 40s to 50s. Now he's at 35, but it's a little bit elevated, and I don't know what the cause of his fever is, but it's not enough to explain that much hyperventilation. That's a lot of that is serious hyperventilation to get your PCO2 down to 12. So that can be central. You can have central hyperventilation, but I don't think it's hypoxic hyperventilation. Now, if his PO2 was 80 with a PCO2 of 12, first of all, he'd have a really high AA gradient. And then I'd be thinking, yeah, maybe he has to breathe that much to get to reasonable O2 sat. So does that help? At least that's the way I'm thinking about it. So Carl, you can ask Stephen any question about the patient now that we have all this information. And the ABG was on room air, Vanita. Stephen had mentioned that.
Yeah, I'd like to know, how long has he been having a fever for?
Yeah, he's been having a fever for about 2 days now and felt weak for the same period.
And what does he mean by weakness? Is it like diffuse weakness or like any muscle aches that are going along with it?
Yeah, so no muscle aches. He just feels sort of a global weakness. It's not lateralizing to a side.
Mm-hmm. Any like respiratory symptoms, shortness of breath?
Yeah, he feels some vague shortness of breath. It's not the thing he complains about the most, but you do capture that on review of systems.
Has he
So
taken
Libby,
anything at home for his symptoms? Like any has he taken any over-the-counter medications for his symptoms?
Yeah, he's been taking some pain relievers. because he said this all started a few days ago. He was fishing and he fell in the boat and hit his knee, and it's been hurting really bad.
Libby.
What's his past medical history like as far as chronic conditions?
Okay, so first of all, I have to compliment Libby. This is what the clinical problem solvers call the background, and the fact that you immediately want to know who this guy is. All we know up to this point, and it's because we're focusing on the labs as giving us clues. So we saw these labs, and then we got called by the ER to come down and see him. So now we're going down to see him and say, we better find out who he is. So that's really spot on, Libby.
Thanks.
Yeah, so he has hypertension. You guys were asking previously about his kidney function. He's got CKD 3A, and he's got OA in his right hip.
Okay. Medications that he takes?
Just ones related to his chronic comorbidities. He takes amlodipine. He takes losartan.
Okay.
And so, now that we've gotten some background, are there any additional labs that you guys are interested in that might help kind of cinch the diagnosis?
I still want to know his lactic acid.
Yeah, absolutely. So you're using the KILU and going down the list. So his lactic is 2.1, which here at UAB is within the normal range.
Boring.
Boring.
About like a septic arthritis or something related to the knee injury. So I'd like to know like white blood cell count.
Yeah, his white blood cell count is 9 with a normal diff.
Got a mention of a salicylate level in the chat.
Yeah, for his, or is he taking that a lot for his OA?
Yeah, so you get a salicylate level and it's 54. In most labs, less than somewhere between 10 and 30 is considered therapeutic. What do you guys make of all this?
Are you satisfied that you solved it?
I feel decent.
Well, the normal lactic acid means that you're not really worried. And we're going to look at his knee, and he probably has a small infection, but he doesn't have a life-threatening infection. He does have a life-threatening salicylate level. The creatinine 1.6 probably is, and Stephen, thank you so much for saying 3A. Carl, do you know what chronic kidney disease 3A is?
No, I don't.
Good, you're about to learn. Libby, can you teach him?
No, I can't teach
So you're
him.
about to learn also. Okay, so back when you were in medical school a long time ago, they probably taught you that class 3 was 30 to 60. Now, they should have told you 3A and 3B because that was changed in the KDIGO guidelines maybe like 7 years ago now. 3A is 45 to 59, and 3B is 30 to 44. And the reason that's important is 3A probably is not even really serious kidney disease, where 3B you start to get metabolic complications. And so what Stephen did is he didn't just tell us the patient had CKD, he told us how much CKD. I'd have to do the formula, but I bet 1.6 is about where he lives. It might be up a little bit, he might be a little volume contracted, but I'm not going to get too excited once I know that he already has 3A. As his primary care physician, I'm going to be excited because I need to make sure that he doesn't progress. It's good that he's on losartan. I'm going to check albumin. But that's not why we're doing this case. We're doing this case to figure out why he had an acid-base disorder. So I think we ought to stop and let Lindsay go over what the real teaching points were about this case, and then sort of wrap us up.
Perfect. Excellent job, Olivia and Carl. Super impressed by y'all thinking through this case. It's very difficult, especially when we bring in delta gaps and AA gradients, and super impressed by both of you guys. So we started off first reflecting on the case, and I'll just hit 2 high points just because I think repetition and hearing these things over and over and over again will only help solidify you, and then you'll just have them memorized for next time. So first thing that I took away was an elevated bicarb. Your first clue is to look at the potassium. If the potassium is low, think about the low urine chloride state, so the saline non-responsive cases, to see if that may give you a clue and point you in the right direction before you even order that lab. And number 2, most of our cases of primary hypoaldosteronism won't have a metabolic acidosis or hypokalemia. So think about that in a young person who's presenting with hypertension. And then we moved into our case. We had a middle-aged man with fever and weakness. And the first thing we started talking about after Carl beautifully went over the labs was the delta gap. There was some confusion in the beginning, but now I think we've all kind of understand a little bit better about the delta gap. So it's the observed anion gap. So what you calculate based on what your BMP shows. And remember, we don't correct the sodium for the glucose in these cases. So you get your observed anion gap, and then you subtract your expected, which a quick way to figure out what that's going to be is your albumin times 3. And then once you subtract that, you add that number to the bicarb that's measured in the BMP. If that is in the normal range, you just have a primary process and you don't have an extra process on top of that. And then we went in and talked about anion gap and the causes of anion gap. Metabolic acidosis, and we can use one of the mnemonics, kill you. We'll start with ketoacidosis. Some pearls from that section is any anion gap over 25, you should be able to identify the unmeasured anion. Anything less than that, start to think about maybe starvation ketoacidosis and hold on your workup or a really extensive workup until you rule that out or find another cause for why that is elevated. And then ingestions, we moved to the ingestion section. So salicylate overdose, Olivia reminded us really in the beginning that you primarily see a respiratory alkalosis. You can also have issues with ethylene glycol, your toxic alcohols, and methanol. The clue to that will be to be sure you check an osmotic gap. And then a pearl about acetaminophen, oxyproline will build up, so you can send an oxyproline level. And then we move to our lactic acidosis. So you can have a type A, type B, or type D lactic acidosis. The type A is the one we see the most common with hypoperfusion and death of tissues. One pearl about that is your lactic acid will rise before your anion gap. So if you're really suspicious of hypoperfusion or tissue death, check that lactic acidosis and then repeat your BMP later if your anion gap isn't elevated off in the beginning. And then you have your type B, which we think about liquid tumors. Don't forget about IV lorazepam. We don't use this as commonly in the MICU anymore for our drips for sedation. But if you see a patient in the ICU on IV lorazepam drip, most of the time greater than 7 milligrams per hour, this can break down into propylene glycol, which will cause an elevated anion gap metabolic acidosis. So keep that on your differential. And then D-lactic acidosis is more gut related, like short gut syndrome. And then lastly, uremia with our phosphates and sulfates. And then we went in and talked about what is acute kidney injury. And you really can't call an elevated creatinine acute kidney injury unless you have a 0.3 rise in serum creatinine over 48 hours. So not the first time you see the patient, not the first time you check the labs, but give it a day or two, make sure it's not just dehydration and the patient needs fluid, because that's not a cure of an acute kidney injury. They may just be dehydrated. And then we went over the Winters formula. Make sure you use the bicarb from the ABG and not the BMP. And then we talked about the AA gradient. And that I will have to have some review again in the future because I couldn't take as many notes on that equation that Dr. Centaur just rambled off from memory. I wasn't fast enough. So next time I want to talk about AA gradient again. And then we got back to the very end where Livy was talking about the importance of layering the background onto the foreground. Who was our patient? Who are we talking about? Which came to be really important in this case when Stephen mentioned that he had fallen, hit his knee, and was taking a lot of over-the-counter medications for his osteoarthritis and then his knee pain. And our end diagnosis was a salicylate overdose with a salicylate level of 54. And one final teaching point for the end of the night, thank you everybody who's staying around and listening this long, is CKD 3A and 3B. 3A is a GFR of 45 to 59, and 3B is 30 to 44. And the reason why that's important is you don't start to see your metabolic complications until you reach stage 3B, and that's why those two were separated. So thanks everybody for coming.
Stephen, if you could just, I know you typed it in the chat, but why don't you just recount what happened to the patient?
Yeah, so when he was fishing, he fell on his knee while he was drinking, and he actually had a patellar fracture. So he was at home in a lot of pain, and as a couple of you in the chat had pointed out, had been taking a lot of salicylates. So you guys were spot on. Salicylates can cause hyperthermia, they can cause weakness, they can cause pulmonary edema. And the acid-base disturbance he had was very consistent. So he didn't need dialysis. He just was managed supportively, and his gap resolved, and he felt better after a couple of days.
Great, thanks everyone. If anybody has any feedback on how we could do this better, or if you're happy, just let us know. We really appreciate it because we want everybody to have learned something. And
Yeah.
Carl and Libby, thank you for being so brave and working so hard to figure out what was going on. And hopefully you both learned something from this too.
Oh yeah, I learned a lot. Thank you so much, Dr. Centaur, and to all of our chiefs and rising chiefs for all this and putting it together. And thank you, Carl, for going through this with me.
Yeah, thank you all. It was a great learning experience. So thanks. I look forward to seeing you all again. Thank you.
Can't wait to meet you in person, Carl.
Yep, you as well.
Once they let me back to the hospital.
Yeah.
Well, we'll see everyone next week, same time, same place. And you can follow us on the Twitter. We're limited by our characters, so it's @unremarkablelab. But we'll send out. You can send out some of our schemas there and some updates on when we have our episodes. And please send us feedback as we kind of get this going.